So when you get started, it's important to start with a dry lab on the Da Vinci, just learning how the instruments work, getting used to handling them, getting used to how the Da Vinci works. You learn the instruments, and then just observe operative videos of select procedures, just standard procedures, pyeloplasty, nephrectomy, ureterostomy, and so forth, just to see how things are done. And then you go to the wet lab, and with a pig model, and you can do. And then there's a simulator. If you have the raw simulator, or if you have the SI simulator. Assist in the OR. That's very helpful to learn, just to understand how the Da Vinci works. And then the first number of cases are going to be proctored, and that's how long proctoring is necessary remains to be determined. I think the ideal first cases are nephrectomy or nephroureterectomy, or possibly a pyeloplasty in an older child or an adult. Now you're going to say, well, I don't need it I already do laparoscopic nephrectomy, and that works fine for me. I don't have any trouble. But you need to be familiar with the equipment, how it works, how you work on the machine. If you just do it on a select few cases, you're not going to become very proficient. So it doesn't mean that you have to do robotic nephrectomies for the next 10 years, but while you're getting up to speed, it just helps everybody on your team get used to using the robot.
We need to allocate the manpower, and we need to allocate the people that you can send for training. You can't just whisk away 10, 15 people from a system to train them in robotics if it's not going to realize its potential within a limited period of time.
A couple-day course with a pig lab is the bare minimum to get started. That just sort of gets you an understanding of the program, but you really have to spend much more time training and learning. The initial step should be learning the function of the robot, and the dry lab is a useful place for that. This can be practiced over and over again before a patient comes into the room, so that the team is very efficient at getting things set up. Learning and understanding the procedure is also critical for residents and fellows who may not have quite as much experience with open surgery or laparoscopic surgery. They need to understand the details of the procedure, the anatomy. These are basic things to say, but it's critical, and by observing the anatomy that can be seen during robotic procedures, anatomy can be learned. Video review and live case observation are really important, especially if you have a preceptor you're going to be working with to learn that preceptor's technique, I think.
Why is this training so important? It's no more see one, do one, teach one. FDA has made it mandatory and instructed the Intuitive Surgical Company, the manufacturer of the Da Vinci system, to give a comprehensive training to all the surgeons who wish to sit and practice at the Da Vinci system. It's definitely a superior technology than laparoscopy. It's not easy, but lesser learning curve compared to laparoscopy, better ergonomics, user-friendly and surgeon-friendly instruments. Docking I felt difficult and needs more practice.
So it's not just the surgeons who will need the training. The assistants, especially the first assistant, the OT technicians, the technical maintenance personnel, which is hugely important. There is a registry for the robotic surgery people that we maintain in our institute, and there is a person for entering data and all, so we have that also. But the principles can be well understood from laparoscopic surgery books, and the more important things is port placement for the right lobe, for the left lobe, and things like that.
I don't think it's like the prostate where you can go from open to robotic directly. So in order to, I think, have a successful robotic liver resection program, we have to understand the principles of laparoscopic liver surgery. And if you can really absorb all these concepts, then incorporating the robot into that practice is not going to be difficult. But I really believe in this, that those of you who are going to go into robotic liver surgery really need to understand the concepts.
When you come back, you should have proctorship or mentorship for your first 5, 10 or 20 cases. Then only you can complete a procedure successfully, and then the mentor can correct you, mentor can help you. And now with this multi-specialty use of the robot, even if you have a senior robotic surgeon in any other specialty, he can give you a cover, and you can start your program, and then you will learn the things in a much better way. So learning is a continuous process. It is cannot just finish in 2 days or 5 days training or orientation program actually.
It's important to minimize the interval between training. This applies to any new technique or device. So once you train, that interval between getting trained and doing your first case should be short. Start simple. You know, I say this all the time, and it always amazes me how often I see this rule violated. Crawl, walk, then run with your cases. And again, the surgeon needs to be committed to get through the learning curve. Without that commitment to do cases regularly, to get through the learning curve, there is no reason that individuals should start to go down this pathway.
The idea behind this is just to really exemplify that where there's a will, there's a way. And with robotic surgery, it's really amazing what we can accomplish. And it's just a matter of figuring out how to either replicate or sometimes even improve upon the open technique inside the body.
So when you start off with, use the robot for simple cases, but then once you get comfortable with using the robot, and I don't know when that will be, it could be 30 cases or 50 cases or 300 cases, you'll find, or my feeling is that the robot is better for the tougher cases that you would have done open, because you know, there's very little collateral tissue damage. You can go where you want to and then figure out what you want to do. But you do need to plan this. We had done this case. We'd done 6,000 robotic cases, but I called Ronney. I asked him, how do you loop it? What loop do you use? Are there any special things? Because I knew he had 5 cases that he had done, and I had reviewed that the paper that he had, and I wanted to get every benefit that I could before trying it on the patient.